stage, it's unfair to make that. Let me see when your kids grow up and you.
My kids have grown up.
Sorry to disturb this vibrant chatting, ma'am.
चालू हो रही है
Dr. Tejkekal, sir,
करें.
Dr. Tejkekal, sir, with your due permission, should we begin, sir?
Absolutely.
Yes.
Over to you, Dr. Nishkarsh. Please, sir, carry on, sir, please.
Thank you, sir. So, good evening, everyone. I welcome Tejkekal, sir, veteran RSACP, Vice President Dr. Naveen Malhotra. Dr. Indrani is probably not there. Then Dr. Anju Grewal, ma'am, and Vishal Singla, sir, he's Secretary RSAP, and all my seniors, colleagues, and mentors. So we'll be having this interesting webinar today. The theme is recent advances in pediatric anesthesia, facts and myths. So we'll be having two talks today. First, I'll invite the chairpersons for the first talk. So Dr. Usha Saha, all of us know, she is a well-known pediatric anesthesiologist from Department of Anesthesiology, Lady Hardinge Medical College. She has been mentor to many PG theses in pediatric anesthesia. She is ex-head Delhi University Department of Anesthesia as well. She has been in key positions in various national and societies. Presently, she is president of Neonatal Society of Anesthesia, which is probably the only neonatal society catering to very small kids, and she is editor for the textbook on neonatal anesthesia as well. Welcome, ma'am.
Thank you, Dr. Nishkarsh.
Then we have Dr. Sujata Chaudhary. Ma'am is Director Professor at UCMS and GTB Hospital. Ma'am is a very key person in teaching skills at various levels, including airway, BLS, ACLS, and has been part of many workshops, and she has conducted as lead faculty as well. Ma'am has written various articles and book chapters, and she has a key interest in airway, resuscitation, trauma, and obstetric anesthesia. Welcome, ma'am. And
thank you, Dr. Nishkarsh. Thank you.
So आगे जा रहे हैं. And for the first talk, the third chairperson, Dr. Anjali Chhabra. Ma'am is professor in Department of Anesthesiology, Pain Medicine, and Critical Care at AIIMS Delhi. Ma'am has a very special interest in regional anesthesia, ultrasound guided, and well published in high impact journals. And she has also a keen interest in pediatric and ophthalmic anesthesia. And welcome you, ma'am. Now I'll request Dr. Usha ma'am to invite the first speaker for today.
Thank you, Dr. Nishkarsh. And at the outset, it's a pleasure for me to be here. And I'm honored that you people thought of me and brought me here today for chairing this session. And my co-chair, Sujata and Anjali, we are meeting after a long time. And you be careful while you're driving. Don't keep looking down at the phone. This is a dangerous thing you can do. Please keep looking up. Please keep looking up.
Okay,
sorry, this is out of context, but I'm just saying, please, driving ke samay, don't do all this. Be careful.
Oh,
so
okay,
I thank
you.
Yeah. So I've been a member of the Research Society of Anesthesiology and Clinical Pharmacology since 1981, when we joined post-graduation at AIIMS, and that was when this society was made. So we are all initially, since then, the part of this society. And I'm very happy to be here today. I thank Dr. Indrani Kumar, the president, Dr. Vishal Singla, the secretary, and Dr. Nishkarsh for inviting me for this. So today, when he asked me, I found it very difficult, and I was asking, why have you chosen me for this topic? It's a difficult topic, I think Dr. Major General Navdeep Sethi has got, which is conundrums, kiddie conundrums. It's so difficult to understand how this relates to anesthesia. So I am sure this is going to be a learning session for all of us, especially for me. What is kiddie conundrum? How is it related to the anesthesia in kids? I request Dr. Anjali, to please introduce Dr. Navdeep Sethi now.
We are all honored to have Major General Navdeep Sethi talk on kiddie conundrums. And we all know he's a very well-known pediatric anesthesiologist. He, long back, I think about 20 years back, he was here with us at AIMS, and he left a lasting impact. And I think we should now, without wasting any time, let him talk about the conundrums that he's going to be talking about. And like Dr. Usha, I have also been very curious as to the topics he's going to cover. And I think he's got a large number of subjects that he has to cover in a very short time. So without wasting any more time, I'd request Dr. Navdeep to start his talk. Thank you, Dr. Navdeep.
Good evening, ladies and gentlemen, and thank you, Dr. Usha, and thank you, Dr. Anjali, for those most kind words. I hope I'm audible. And
Yes, sir, you're audible, sir. Very much audible, sir. Please go ahead.
Yes, you are all right.
Screen.
We
Okay.
can see your screen.
Yes, sir.
You are audible.
Thank you, ma'am. So my topic is Kiddie conundrums, and I bring you greetings from the Yashoda Super Speciality Hospital, where I am presently employed. In life, it is the small things which are the most important. And what can be more important than small babies and the not so small problems which they often carry with them, especially in pediatric anesthesia. So today I'm just going to give you an overview of some of these vexing problems which we face when we are handling babies and anesthetizing them. So some of these issues which we encounter may be either in the operation theater, preoperative, intraoperative, or postoperative, or they may be while we are engaged in giving non-operating room anesthesia. Coming now to the preoperative issues. Upper respiratory tract infection is among the commonest problems which we encounter. Previously, it was almost always no if you encountered a sniffling child in the morning. However, it's now mostly yes, you will go ahead with the anesthesia. So when do we need to postpone elective surgery? Emergency we'll do in any case. So elective surgeries, generally the recommendation is you postpone them for at least 2 weeks. If the parents say their child is unwell, the child has fever or mucopurulent secretions, or the X-ray chest shows lower respiratory tract infection. Because we all know that in this scenario, the incidence of perioperative respiratory events increases. The next problem is parental separation. This is a problem 6 months to 6 years of age. Oral midazolam, 0.5 milligram per kg is universally used and it's very efficacious. Recently, nasal dexmedetomidine is becoming popular in a dose of 1 to 2 microgram per kg. And it acts even quickly, like midazolam will take 20 to 30 minutes, nasal dexmed within less than 10 to 15 minutes. And if we allow the mother inside the OT and the child is in a mother's lap, generally we find that it has a calming effect on the baby. You may use Emla cream even if you're not planning to start an IV outside the theater, because it will definitely help you during your servo induction. In case an intravenous line is already there, then of course you could give a small dose of midaz, ketamine, and propofol to the baby before taking into the theater, because we all like to have a small, quiet, sedated baby coming into the theater. Intermuscular ketamine, very rarely, if at all, needs to be used. Laryngospasm is another common problem, and it used to be extremely common, when we were using halothane and in the so-called good old days. However, the incidence is now, thankfully, reducing. It still remains, however, nearly 2 to 10% and is more in infants and children who are nursing a URI because they have a reactive airway. The cause is usually glottic stimulation in light plane, which may be during intubation, extubation. or the child is, crying preoperatively with a lot of secretions that may again provoke laryngospasm. And if you attempt to do suctioning in a light plane, you will certainly provoke laryngospasm. So if it is incomplete, that means you can hear probably a stridor, and there are some chest sounds. Pressure on the laryngospasm notch, which is on just behind the angle of the mandible below the tragus, that's known as Larson's maneuver, along with oxygen and CPAP, usually helps to break this laryngospasm. You can give a small dose of propofol to deepen the anesthesia. However, if it's a complete laryngospasm, that means there's no air entry, and the child is rapidly turning blue with the stats falling, intravenous choline 0.5 to 1 milligram will immediately relieve it. In case you don't have an IV, then 2 milligram per kg intralingual or 4 milligram per kg intramuscular can be safely given. You must watch out for post-obstructive pulmonary edema in case the child has had a laryngospasm. Briefly, just telling you about one lung ventilation, which is challenging in kids, mainly because you've got a very small trachea there. It's almost just 4 mm at birth. And each bronchus itself is just 1 to 2 mm. Left is still relatively free. The right, the upper lobe takes off quickly, so it's a difficult one to block. There are options: a single lumen endotracheal tube, a bronchial blocker, a univent tube, or a double lumen tube. To summarize the options as per age, if it's a 0 to 6 months child, a single lumen tube is the simplest and the best option. From 6 months to 8 years, you have the bronchial blocker. Fogarty was traditionally used, but the newer Fuji and the fiber optically guided ANT blockers are possibly better and more versatile. Beyond 6 years, you can use the univent tube, but it tends to get dislodged. And beyond 8 years, it's generally advisable to use a double lumen tube if so required by the surgery. Just to give you an example, this is a case of a congenital lobar emphysema left-sided in a 3-month-old baby. And we have done right-sided bronchial intubation with a 4 mm endotracheal tube. And at the end of surgery, we pulled the tube out so that the child could be ventilated by both the lungs. The Fogarty blocker can also be used and was traditionally used. We have used this in this 4-year-old boy using a 6 French Fogarty with a flexometallic tube. It's a left-sided cystic adenomatoid malformation. So we place the blocker in the left and the endotracheal tube on the right side initially. Later on, we withdrew it into the trachea. The ANT blocker is a newer blocker which can be guided fiber optically into the required bronchus. It's into the left bronchus in this case. It comes with a special adapter. And a double lumen tube is possibly the best option for the older child where you require it. That means if there are infected secretions and you don't want the healthy lung to be soiled. In this particular case, we have used a 26 French double lumen tube in this 10-year-old boy. And this lung cyst was successfully removed. What about IV infusions? Now, preoperatively, you may require them for cases of intestinal obstruction in babies, gastroschisis, trauma, burn, sepsis, or prolonged NPO. Fortunately, prolonged NPO is now uncommon. Ringer lactate or blandin salt is still the advocated fluid for pre-op resuscitation. What about intra-op infusions? Now, if the child is NPO with less than 1 to 2 hours, and for a short surgery or a CT scan, and you supervise post-op, you possibly don't need an intraoperative infusion. Just an IV cannula should be sufficient. Most other babies would require an intra-op IV fluid, and the majority of people would now prefer balanced salt or Ringer lactate as the intra-op fluid of choice. Because previously we used to give hypertonic fluids, and in the setting of post-operative antidiuretic hormone secretion, the babies invariably went into hyponatremia. And if you use normal saline in large quantities, It's associated with hyperchloremic acidosis, hence the balanced salt solution. Ringer lactate is commonly available. Most other companies have their own version of the balanced salt solution. You could choose which one as per your preference. The classic Holiday and Seger rule still holds true for intraoperative replacement of fasting deficits, maintenance, third space, and blood losses. I'll not go into the details. It's well known to most. However, post-operatively, instead of 4:1, 2:1.5 is now suggested as this is ml per kg because of the antidiuretic hormone secretion in the post-op period. And we don't want to overload these babies. Another contentious point is whether to give glucose or not to babies. Now, routinely, healthy children would not require glucose in the perioperative period. We know that both hypoglycemia and hyperglycemia are harmful and may lead to neurological damage. Glucose, if we need to give, then instead of 5 to 10%, we now advocate 1 to 2.5% in balanced salt solution. And this is especially advocated for prematures or neonates, babies of diabetic mothers, babies undergoing hyperalimentation, or those with documented hypoglycemia, and it's advisable to monitor the blood levels in these children. Blood loss is often a vexing problem. The accepted hematocrit is 20% in the child and 30% in the neonate. The ratio of balanced salt to blood is 2:1, and the ratio of colloid to blood loss is 1:1. It's always advisable to calculate the maximal allowable blood loss, taking the estimated blood volume to be about 80 ml per kg in the neonate and 90 ml per kg in the preterm. Alternatively, you could calculate the fat RBC required as the body weight in kg multiplied by the hemoglobin increment desired in grams into 5. Now, massive blood loss, that is about the entire blood volume in 24 hours, or 50% of the blood volume in 3 hours, or 10% within 10 minutes. So the speed of loss is also important, and you can anticipate such massive losses in cases of croniosynostosis, scoliosis, trauma, cardiovascular surgery, or neurosurgery. Now, coming to some anesthetic concerns which are peculiar to pediatric laparoscopy, which is becoming increasingly popular nowadays. You have to contend with the problems of raised intra-abdominal pressure because that may have hemodynamic, you may lead to hemodynamic compromise. The PaCO2 tends to rise because the insufflating gas is carbon dioxide. A positioning of the baby is often, head down tilt, and a steep tilt should be avoided because it has a splinting effect on the diaphragm and the FRC falls precipitously. You must contend with physiology of the neonate, which is different from the adult, and always watch out for surgical complications like perforation. So some common do's and don'ts for pediatric laparoscopy: ensure smooth induction, because if the stomach fills with air, the surgeon will have a difficult time operating. Keep your intra-abdominal pressures less than 12 millimeters and a head low less than 20 degrees to prevent cardiorespiratory compromise. Adjust your IPPV and monitor your EtCO2 levels, and keep your cool because the surgeon often does not keep his. The next problem we sometimes encounter is a foreign body bronchus. This is always a challenge, especially if it's an organic foreign body like a peanut which breaks and irritates. It's better to avoid sedative premedication. There's a controversy. Should you use spontaneous or should you use controlled ventilation? Well, I personally prefer assisted hand ventilation using the ventilating bronchoscope, which is commonly employed. You could use either scoline or atrachurium. If you opt for spontaneous, the only catch is that you have to keep the child deep, and that has got its attendant problems, especially at the end of surgery, laryngospasm and other issues. And during the surgery also, you may keep disturbing the surgeon because the child's level of anesthesia keeps altering. So I personally feel that assisted hand ventilation gives you a better control over the respiration of the baby, and the surgeon is able to operate at leisure. Post-op subglottic edema often takes place, and you must always have nebulized adrenaline and dexamethasone, nebulized and or IV to cover this eventuality. This is a 6-month-old baby in which there was a left-sided foreign body which we've extracted. And this is the surgeon who was removing this foreign body with a ventilating bronchoscope. Now, coming quickly to some neonatal emergencies. They're usually in the first week of life. The problems are triple. Firstly, prematurity, like respiratory distress syndrome, congenital anomalies, especially congenital heart disease, and problems of the disease itself. So what are these problems of the disease itself? I'll just tell you an overview. So when you have a case of a congenital diaphragmatic hernia, usually you will find that you have to contend with malformed lungs and persistent acidosis. For the surgeon, he may finish off the surgery in half an hour, but in the perioperative period, especially the post-op period, you'll have to really monitor this baby in the ICU very, very closely. So in this case, you can see this is a case of a congenital diaphragmatic hernia, and the left-sided lung is hardly formed. The child had severe acidosis also. Gastrochisis, there's a lot of, since the intestines are exposed, there's a whole lot of blood loss which takes place. And you have to resuscitate these babies preoperatively as well as intraoperatively. And it's elder brother exemphalos. There may not be so much of fluid loss, but the child has invariably multiple congenital anomalies. Now, this is another neonatal emergency which we commonly encounter. Meningomyelocele. The problem would be in intubation. You have to support the meningomyelocele so that it does not burst. And you have to later on position the baby prone and see that the abdomen is free and does not compromise his respiration. A hydrocephalus, with or without shunt placement, is often encountered. And one is, of course, the intubation, which you have to, it's a little different because the head tends to get flexed. So you may have to put a roll below the shoulders, and the ICT or the intracranial tension is likely to be raised. So you have to make sure that you do not let it rise precipitously. And then, of course, this is a common TEF or a tracheoesophageal fistula. The tube has to be placed between the fistula and the carina. And you also have to contend with lung soiling, which is almost invariable. So this is, of course, in this patient, this is the fistula. So coming now to spinal block. This is definitely recommended for neonates and children. One of the advantages is that there's cardiovascular stability because this sympathetic nervous system is less well developed. There is less of venal pool in the lower legs, and there's a large spinal canal. So you can get away with a spinal quite safely in babies. The average dose is 0.5 milligram per kg, employing 0.5% bupivacaine, L45 space or below, 25 to 26 gauge needle, and you must use the pediatric silicate needles, 25 to 50 mm. The duration of your spinal block, however, is shorter in babies, 45 minutes to 1 hour. Continuous epidural is now the standard of care for major surgeries in babies, and for thoracic, abdominal, and lower limb surgery, major surgery, a continuous epidural offers tremendous benefit. As you can make out, this baby is fast asleep in the post-op period following major abdominal surgery. What about regional blocks? Well, thanks to the ultrasound, is no longer a dilemma, definitely advocated, and one should give a regional block in babies wherever feasible, and wherever feasible, it should be a continuous block. A word or two about non-operating room anesthesia. Now, MRI is one of the commonest places we have to go for this, for anesthetizing these babies. The child needs to be sedated for 15 minutes to say 45 minutes or so. They're usually sick babies with congenital anomalies, and you're working in an unfamiliar surrounding. The magnetic field is strong, so equipment have to be chosen carefully, and it's noisy, which means you must leave your watch, your wallet, etc., behind, as of course not carry any metallic object which will get pulled into the gantry. An NMRI compatible anesthesia machine and a patient monitor should always be present and insisted upon. The technique varies. A very small baby, a neonate, can be breastfed for short procedures, and well swaddled, it will just go up to sleep. However, the majority will require either TIVA, LMA, or endotracheal tube, depending upon the procedure and the condition of the baby. This is a very small baby who was there for a whole body MRI, and we intubated this child and extubated at the end of surgery. A common problem, which is probably among the most vexing, is a central IV access. Now, the dilemma is the child has got no IV and he has been sent to you for a central IV. So do you put an IV first, a peripheral IV, or you straight away proceed with GA? Well, I don't know the consensus, but I feel that most of us would, start an IV in the first 15 minutes or so. And majority of times under, sevoflurane and spontaneous, you'll find the veins tend to open up, and you will find a vein either in the antecubital fossa or in one of the other places where you may be able to manage either on the hand or the feet. GA, you can use an LMA or endotracheal tube, but must watch out for the complications of bleeding and pneumothorax following your procedure. If you must use an ultrasound in very small babies and have lots of patience, because at times it takes a long time to cannulate their central vessels. This particular baby came to us for a central IV line, and fortunately we were able to put an antecubital cannula in the left antecubital fossa and then proceeded with GA to place the central line, and we placed a right jugular in this case. Now coming to the post-operative problems, well, a post-intubation croup is among the common problems. Incidence 1 to 6%, and usually a tight fit tube is implicated for this, especially if there has been some trauma during your intubation, or the child has been bucking on the tube, or it has been a long head and neck or ENT surgery. It generally presents with stridor in the first hour, and a subglottic edema is the cause. It responds to nebulized adrenaline, oxygen, and IV dexamethasone. Post-op apnea is another vexing issue. The predisposing are preterm babies, especially with inhalational or GA, opioids, anemia, hypoglycemia, and hypothermia. Generally, this is a distinct entity up to a post-conceptual age of 60 weeks for the preterm or 44 weeks for the term baby. That's why, in fact, spinal analgesia is recommended for inguinal hernia repair in preterm infants to prevent these babies from going into post-operative apnea. And finally, emergence delirium. Now, emergence delirium is generally a problem within 1 to 5 years of age. The incidence varies. It's 10 to 80% with an average of about 20% or so, more in ENT surgery. It generally, the onset is within 30 minutes and it lasts for a maximum of 30 minutes. Usually, may last longer. The predisposing are the newer inhalational agents, especially sevoflurane and desflurane, though isoflurane has also been known to cause it. The cause is still obscure. Majority of times, we tend to ascribe it to either pain or anxiety in the baby, which was there before the surgery. For prevention as well as treatment, fentanyl, dexmed, propofol, and midazolam have been advocated. Fentanyl and dexmed are possibly the first choice, followed by propofol and midazolam, because they take care of the pain also. Recent studies now, this is a post-operative neurotoxicities or cognitive dysfunction following GA in small babies. There was a lot of studies on this. But most recent studies, including the GAS study, the PANDA study, and the MASK study, have brought out that short exposure less than 2 hours to GA in neonates and children less than 3 years does not result in adverse neurodevelopment outcome as of now. But the jury may still be out on this, so we'll have to wait and watch. As of now, short procedures are possibly safe in babies. Lastly, a word or two about prevention of perioperative cardiac arrest. The incidence of perioperative cardiac arrest is 2 to 3 per 10,000. Maximum is in infants, especially ASA 3 to 5 babies who are there for emergency surgery. So the recommendations are infants and high-risk babies should be managed by experienced hands, people who are used to handling babies. Sevoflurane is advocated as the anesthetic of choice, and standard monitoring must be established in all babies, even for short procedures. You must limit scoline to rapid sequence inductions and laryngospasm. Regional anesthesia, whenever you employ, always aspirate and give small increments. And when you're putting a central line, always use the ultrasound. The ultrasound is advocated for even regional anesthesia wherever practical. I mean, for a caudal, you can safely give a caudal, but if you want to give one of the other blocks, if you want to give a supraclavicular block, then you must use an ultrasound. So life is not waiting for the storm to pass, but it's about learning to dance in the rain. So similarly, in pediatric anesthesia, you have to learn to manage these complications with care and due diligence. And if you looked after these babies, they will always be happy and smiling in their mother's arms in the post-op period. Thank you.
Thank you, Dr. Sethi. It was a lovely talk, and you have covered it very well in such a short time. And I'm sure the residents and all must have gained a lot of information from here. Dr. Sujata, would you like to sum up and say something about the talk?
Yes, thank you, Major General Sethi. Yes, covered the topic so extensively and covered almost all the concepts which are especially for the pediatrics. And one thing which I have come to know or I've noticed is that when we talk about post URI, earlier we used to say we have to wait for 4 weeks for the child to recover because otherwise the airway remains irritable. Now this concept of 2 weeks, it is new for me. This I have not been aware. And rest of the things he covered about the neonatal aspects also very extensively and very nicely covered. Thank you. Thank you, Dr. Sethi.
Dr. Anjali, you want to say something?
मैम आपका म्यूट है.
मेरा म्यूट है, sorry. नहीं.
डॉक्टर अंजलि का.
You are mute, Anjali. Speak up. Unmute yourself.
Yeah. I'm unmute now. And again, I'd like to congratulate Dr. Sethi for this extensive talk. I just have a few points to add. When we are talking about preoperative separation from the parents or preoperative anxiety, I think our residents and we ourselves need to develop, these ANTs or anesthesia non-technical skills. Most of the times we don't tell the parents what to expect. So if the parents know what to expect and we make them a part of the induction process, it becomes very easy to induce the child, making the parent participate in the process of induction. And other thing I'd like to talk about is midazolam, oral midazolam that we are taking. We're usually getting concentrations of 1 milligram per kg. So giving it orally becomes a real challenge. And usually, I think, we either have to manage with the nasal midazolam or we'll have to give a lower dose of the midazolam. And as far as the emergence delirium is concerned, of course, it's my pet topic. But if there's a good regional block given, it definitely, I think you alluded to that, but a caudal really helps. And, the patient wakes up so smoothly, even if we've used SIBO and an inhalational agent for maintenance. I think that takes away a lot of the sting of the emergence delirium. So I think Dr. Sethi really wonderfully covered everything up. And it was a pleasure listening to you.
Thank you so much, ma'am. You're absolutely right. 5 milligram per ml midazolam is available, which is actually advocated in a small, syrup of 25% dextrose, 10 to 25%. So 5 milligram per ml is the concentration we must have, you know.
But it's not available in India as of now.
Okay,
Do you have it?
Okay, we were getting it now.
Oh,
So,
Earlier it was.
no, it's the same, you're getting ampoule.
is?
So you have to break it and use it. Now, oral midazolam syrup is also available now. So you have a choice of using either. You're absolutely right. The caudal does help, you know, and cutting down emergence delirium. I agree with you 100%. And your other observation about babies, you know, involving the parents, I think definitely yes. In fact, we routinely allow the mother or the father, whoever is, you know, more comfortable with the baby, inside the theater. And moment the child is asleep, we escort them outside. I agree with you on that count. We need to involve them.
Thank you.
Thank you, Dr. Sujata, Dr. Anjali, and Major General Navdeep Sethi.
Thank you.
Just I will take. I will also want to say something.
You must, ma'am, please. You must.
I agree with Sujata. The concept of babies with URI was waiting for 4 to 6 hours. If it is 2 weeks, 4 to 6 weeks, sorry. If, like you said, it's just more than 2 weeks, I think it depends on the expertise of the anesthesiologist and urgency of the surgery. So a lot of things have to be kept in mind, though we have taken patients earlier also. So that I think depends on your skill. Otherwise, 4 to 6 weeks maybe would be a better or safer option if we tell the residents, you know. Then if you take it earlier, a senior person must always be present to prevent any complications. Now, parental separation is actually a real problem, especially in the kids who are 2 to 5 or 7 years of age, who you are unable to explain or who are not willing to understand. When we were there, even at AIMS and RP Center, the facility to take in the mother was never there. Mother would collapse and you'll be resuscitating the mother, then managing the baby. So that has to be weighed, you know, whether you want the parents inside or not. Yes, the Western concept is taking the parent inside. So we used to sedate the baby outside in the pre-operative room with the parents around, giving them some oral Finargan, or in the oral midazolam nahi tha, so we were using Finargan and atropine we used to give. When the child was sedated, we take the child inside. So these options are available, and according to the availability of drugs, one can use them. It emerges that maintaining adequate depth of anesthesia is most important to prevent complications and problems in the perioperative period. Most important. And remember, everybody should remember that one drug or one agent cannot provide complete anesthesia. So we are ultimately using balanced anesthesia. That means providing good relaxation where required, providing good analgesia, providing adequate cerebral suppression. So these things have to be kept in mind and maintained. I always keep telling my residents that whenever a patient comes, certain things are important. Besides all that we have been talking about, one is the weight of the baby, and calculate fluid for each and every child per hour, depending on the fasting and surgical requirement. Because, you know, many times we don't know when a minor surgery becomes a major surgery. So yes, for very short procedures, maybe just having an IV cannula might be okay. But to be on the safer side, struggling around somewhere, some IV fluids, even if you give it with a syringe, is advised in babies, children who are fasting. And often when we say 1.5 or 2 hours of fasting, it's often more than that. Either the parents are scared to give, or the surgeon is scared the anesthetist will cancel. Like, you know, my husband was asking, it's a 9-year-old boy, usko subah coconut pani de de 3 ghanta pehle. I said, according to me, yes, you can give, but according to your anesthetist, you have to decide. So this thing of 1.5 to 2 hours, usually no anesthetist accepts a child who is just fasting for 2 hours. I've yet to see that anesthetist. So I think we still in an older child, it's 3 to 4 hours at least. Same way, maximum allowable blood loss must be calculated and kept on top for each and every baby, and accordingly blood arranged and provided. Yes, and I agree with Anjali that caudal anesthesia is a much safer technique for everybody to be practiced for any surgery, and it provides beautiful analgesia intra, which can be continued in the post-operative period. And though we have done a lot of cases with spinal anesthesia in neonates, in small babies, it's a very good technique to reduce the requirement of inhalation anesthetic agents and their effect on the developing brain. It is a beautiful technique, but you have to be very, very careful. And I remember we did a thesis with Anju, and we applied for a pediatric needle, we didn't get it. And we were using adult size needles, and we had to be so very extra cautious in neonates to prevent damage of the cord. But often caudal anesthesia has a wonderful effect. It's a very good technique which everybody can utilize.
Yes.
With the epidural catheter continuous, which I have seen is in a smaller baby, how you keep it in position in the postoperative period. The child maybe passes urine or soaks or something happens and the catheter slides out. So you might be injecting the drug, telling your resident, go there every 6 hours and inject the drug, and it's actually not going in. So one has to be sure that the catheter is in place, and 90% of the time catheter comes out on its own, slides out on its own. Just one more. Postoperative apnea and intraoperative or perioperative laryngeal events, one has to be very careful. Smaller the child, greater is the risk of child going into severe hypoxemia and cyanosis. So when we are discussing all these things, it is basically to impart knowledge to everybody that these things can occur, and for us to take care to prevent those problems and complications. And in case they occur, then we must be able to manage those. Thank you, Dr. Navdeep Sethi. It was a very nice talk. It opened up my brain. Thank you so much. Thank you, Nishkash.
Thank you, ma'am. Thank you so much.
Thank you. Thank you.
There is an interesting comment in the chat
Sir,
box.
I have a question for Sethi sir.
Yes,
Can I,
sir.
Yes.
sir, I want to ask about the loading the dose of scoline in laryngospasm, sir.
Yes.
Initially, it was mentioned that it's 1/10 the dose, but
Yeah.
with the SpO2 falling like anything in a pediatric
Yes,
patient,
I think 1/10.
nobody takes
Some
the
books, yes, you're
nobody
absolutely right. Some books mention 1/10 the dose, but I think 0.5 to 1 milligram per kg is a safer dose to give. Some books the newer books have mentioned up to 2 milligram per kg also, because the idea is that you have to quickly
Yes.
break the laryngospasm if it is complete. So I think using just small or 1/10 of the dose is possibly not wise.
No.
So 0.5 to 1 is a safe dose, and you must always follow it with a flush.
Right.
Yeah. So like a 5 kg child, the intubating dose would be maybe 10 milligrams, and 1/10 is 1 milligram will not produce that effect. So 0.5 milligrams, you have to break the laryngospasm. Whether you intubate or not intubate is not the issue. It is just breaking the laryngospasm. So at least a dose of 0.5 is essential. But we have seen in adults, when we go for ECTs, we have seen in adults giving a 0.25 milligram also helps. But maybe we are safer there. Everything is larger. But in kids, we are scared that to prevent, going to more
And
problems.
you need not intubate these babies,
Yeah.
man. Once
Yes.
you can ventilate, leave
Yes,
them alone,
with the mask.
because the catch is when you extubate again, the child may go into larynx.
Exactly.
Yes,
Yeah.
sir. Exactly, sir. Exactly, sir.
And also the positive pressure at times, it's very helpful when we are just
Yes.
using a bag mask ventilation
Yes,
with a
Absolutely.
Yeah.
that
Absolutely.
itself is
Right.
an
That
opening
also
of-
helps. Yes.
Yes, certainly.
Thank you very much, sir.
Thank you.
Thank you.
So there is an interesting comment by Dr. Bhatia sir. So he has a patent on a double lumen tube, which is single lumen but a double curve. Bhatia sir, can you please elaborate on that for a minute, sir?
Yeah, sure. Good evening. That would be my pleasure.
Yeah, good evening.
So it's a unique thing. It's a single lumen, but the curvatures are two, just like a DLT, double lumen tube. So we can have a right-sided tube, and we can have a left-sided tube. So you may ask what is new about it, because it's again a single lumen tube which we often insert in a baby for one lung anesthesia. So the idea of two curvatures is it's always easy to insert and isolate the lung that we desire to isolate. So because we have both sides of tube, right and left, and the curvature are exactly similar to that of DLT, but it is a single tube. Right. So and the length of the tube is slightly it's longer.
Okay.
Because we have to go up to bronchus, so that there is no problem in the connections.
Do you
And
have a photograph
size of
of the tube?
sorry,
Do you have a photograph of the tube or
Yeah, I have. I got a prototype also prepared from
Okay.
Romson's,
That's very
but then
interesting.
they just backed out for the commercial manufacturing of this tube. I
Okay.
had an MOU signed with the Romson's, but then probably they didn't find it. The market size probably was not
Okay.
huge for them. So
Okay. No, that's
commercial
very
production.
interesting, Doctor. Very interesting.
So and the selection of the tube was one size smaller
Okay.
than the regular tube for that child, because we have to enter the bronchus, mainstem bronchus.
Yes.
So in our study, which got published in Pediatric Anesthesia Journal, it was actually what we found, that even our residents could intubate and select that particular side, right or left, in the very first time. We got it checked with the Siam, which is easily available besides auscultation.
These are cuff tubes. Cuff tubes.
No, not cuff tube. Non-cuff tube normally.
Okay. Okay. So they would
Non-cuff tube.
be.
So
Okay.
see, the problem is in the small child, how to isolate. So if the Romson said they were interested, then we could have explored new areas with cuff tube, but we have worked on only non-cuff tube,
Okay.
and we found it very reliable, safe, effective, and then you can easily pull it out for two-lung ventilation also.
Okay.
So that's what.
Thank
So,
you.
so we have different sizes of these tube, or sir, we have a single
Yes.
size?
No. I mean, it can be manufactured. It is not under commercial production right now, but then yes, it can be produced for all sizes of tubes, which is required for that particular age group. So that is not the problem. The designing is different. It's a double this curvature, just like DLT.
Okay. Okay. We've been traditionally using the single lumen tube and pushing it into the relevant side if required.
Yeah. We have experience of that also,
Yeah,
but
that
single
I have
lumen tube.
experience. I have no experience with this.
Wouldn't angle of insertion be different in children, because the bronchi are
More.
What if?
they're more at right angles?
Yeah, exactly.
More in line
I
than
was
in an
wondering,
adult.
actually, the same tube, has an equal chance of going on either side in babies. So if you have left-sided or right-sided, maybe if you see the tube, we'll understand it better, ma'am. Even I could not really make out.
No, but if you have a left and right-sided independent tubes, that means the way you hold it, it will go into the, that side. Just like you have right and left-sided DLTs, and
Possibly, yes.
how you hold
Possibly.
it goes into that.
Possibly, ma'am.
Yeah.
No.
Till you use it.
Yeah. Good thing, ma'am. Good thing.
Thank you, Dr. Bhatia.
Thank you.
Thank you, sir. I think there was some issue with your mic and we could not hear the last words, but yes, definitely the patent is there on the website also. Sir has shared a link.
Okay.
But we'll have to wait some time before we can use it.
Okay.
So thank you very much, Bhatia, Sethi sir, Usha Saha ma'am, Anjoli ma'am, and Sujata ma'am for the nice, interesting talk and discussions. I'm sure a lot of residents have joined lately and they must have benefited from the AVID discussions. So before we proceed to the next talk in the session, so I invite Dr. Vishal Singhal sir to say some words, and Dr. Tej Kaul sir to say a few words regarding the seminar and generally. Tej Kaul sir? Singla sir?
Dr. Tej Kaul sir? Sir is, I think...
He's probably not there. Contemporary.
Sir was there, maybe this... Dr. Vishal, you can...
You could check up, sir, at the end again, I think.
Yes, sir. So,
Yeah.
Dr. Vishal is Secretary of RSACP and...
thank you very much, Dr. Nishkarsh. Greetings from RSACP. Very good evening to all the dignitaries here. Respected Dr. Tej Kaul sir and patrons. President Dr. Indrani ma'am, President-elect Dr. Naveen Malhotra sir, Treasurer Dr. Sunil Sethi sir, Dr. Bhatia sir, and the organizing chairperson of today's program, Dr. Navdeep Sethi sir, and all the other dignitaries on the dais. Today's webinar regarding recent advances in pediatric anesthesia by Team Delhi is wonderful. As expected, the Kiddie's conundrum was exceptionally good. The success to any webinar is by active contribution of the speakers as well as by the chairperson. So I am really thankful to all the faculty who deliberated and who will be deliberating in the next session. I'm sure today's webinar will be quite enriching to all of us. pediatric anesthesia, the subspecialty has evolved because it's altogether different from the needs of the infants and children are altogether different from that of the adults. Their sedation, IV, cannula, pain management, airway management, regional anesthesia is all similar and yet very different from the adults. So we learned a lot of things from the first portion, and I'm sure that the second portion would be equally enriching. I extend my best wishes to the faculty and organizing team, Team Delhi. All the very best. And I would also like to extend my thanks to Mr. Chaubeji for providing us the technical support for live telecasting this session on the YouTube and Anesthesia television. Thank you very much. And also I would like to give one message to all the residents, if we have any here, that please come up with your questions. No question is small. Every question can be is very good. Everybody started his or her career from the from a scratch. Please put in your questions. Thank you very much. Be safe and long live RSACP. Thank you very much.
Thank you, Dr. Vishal. So we'll now move to the next session in the webinar. So for this, I'll invite. So we have 3 chairpersons for this webinar. Dr. Rakesh Kumar, everybody knows, so he needs no introduction. Sir has been a mentor for most of us, including me. And the best part about it is fun learning with sir. So whatever we do, so we don't feel a stress, especially as junior anesthetists, as first year postgraduates, we go into the theater. Sir will make you stand on the head end and sir will be seeing from the side. And senior residents will be jumping around. Because as a first year, you will end up doing some problems, but he'll say, let him do and we'll let us see. Because eventually, as in anesthesia, we must realize that it is the fear that we have to get over while anesthetizing a patient. And sir is absolutely a fabulous person. In fact, whenever we visit him, a lot of my children also, even if they have met twice in about 15, 20 years, so but they will remember sir for life. So this is the personality of sir. So I really welcome you, sir, and it is a great pleasure to have you here.
Thank you very much. So आपने pediatric session में इसलिए बुलाया आपने मुझे क्योंकि मैं आपके बच्चों का favorite हूँ. But
Yes,
I'm
sir.
very lucky that I love that, being with the younger the better. Thank you very much.
Thank
To
you,
the
sir.
whole executive of RSACP, Dr. Indrani, of course. I last saw her on San Diego Beach. So she is in US, I think, and the whole executive, all of you, Dr. Vishal, Nishkar,
Thank you very much.
Dr. Malhotra, and so on. So everybody, thank you very much.
Your blessings, sir.
Thank you, sir. Now I invite Dr. Maitri ma'am. Maitri ma'am is Director Professor and Head Lady Harding Medical College and Associated Hospitals. Ma'am is presently President-elect ISA Delhi branch, and she has been instructor for a lot of skill training courses, including BLS, ACLS, Airway, and FCCS. In fact, today also she was in a ACLS course and she kindly agreed to be a chair for this session. She is well published and she has special interest in pediatric anesthesia and critical care. Welcome you, ma'am. And the third chairperson for today in this session is Dr. Ranju Singh. Ma'am is a Director Professor at Lady Harding Medical College. As Dr. Usha said in the beginning, she has been like this for years since we have seen her. And she is also has a keen interest in pediatric anesthesia, obstetric anesthesia, and life support. Ma'am presently is Vice President of ISA Delhi chapter and instructor for ACLS, BLS, and airway management courses. Ma'am has more than 60 publications in high impact factor journals and lot of presentations to her credit. Welcome you, ma'am. For Dr. Maitri is here, or?
Thank you, Dr. Nishkarsh. I'm still on the move, so I'll just reach in 5 minutes and then I'll join in a better way. Thank you.
Rakesh sir, then you can.
Dr. Nishkarsh, we have Dr. Tejke call, sir. Sir, can we have, please, can we have him on the board, please?
Yes, sir. Dr. Tej, sir. Dr. Tejke call, sir.
Dr. Tejke call, sir. Can you please unmute yourself, sir? Dr. Kaul, sir? Can you hear me, sir? I think let's move on, Dr. Nishkarsh. Probably sir is not there.
So Rakesh sir, you can introduce the next speaker?
Yes, of course. It'll be a pleasure. And the topic, the second topic is almost the same as Dr. Navdeep has already talked about, and that is उसके अंदर थोड़ी अंग्रेजी मुश्किल थी, लेकिन common pediatric airway management problems उन्होंने भी discuss करी कुछ हद तक. So the topic of the next one is purely related to airway management problems and common pediatric airway management problems and their solution. And I have the privilege to introduce to you Dr. Kavita. You know, her CV was running into 3 pages, which the most striking things which I want to share with the rest of the people, audience, is that it shows a keen interest in pediatric anesthesia, pediatric patients, and so on. She is one of the executive members of IAPA, and they recently conducted an exclusive pediatric airway workshop, which was a very successful event. And I was fortunate to be a part of that. But the other thing which I saw in her CV was a fellowship, ICC RETT fellowship, in which she was at Children's Hospital, Boston, Howard University, and in 2009, and she completed a project on management of pain in pediatric patients. So that shows that her keen interest in pediatric anesthesia. And I know her for the last 30 years, and we have been friends, and we have a couple of publications together. It's always a pleasure working with her. As Dr. Vishal has mentioned, no question is silly, only the answers are silly. And she has the habit of asking all those questions. And I love people who ask questions because they make you wiser. They make you look inside, outside, everywhere, and try to find answers. And I never have found it shameful to say that I don't know it today, but we'll do it tomorrow. So that is how we have learned and grown together. At present, I can say very happily that once I left MAMC, she also left MAMC, and she has gone to Vardhaman Mahavir Medical College as a director professor. Just, you know, feeling elated about myself. I'm sure that she was furthering her career, and I wish her all the best. Over to Dr. Kavita Sharma. Kavita.
Thank you, sir. So,
thank you so much, sir. Sir, thank you so much for the kind words. And we will start with the presentation now. Nishkarsh, please start with the
evening, everyone. Hi.
My screen is visible to everybody?
Yes, it's visible, please.
Thank RSACP for inviting me to this platform. RSACP and AMF have worked together on numerous occasions to spread the knowledge on airway management. Recently, the AMF way of airway assessment, that is the line of sight, was also published in RSACP journal. Pediatric airway management is very unique. It is usually easy and simple in most of the cases, but it can become a nightmare for the inexperienced. Reinforcing these concerns for airway management can never be overemphasized. In this endeavor, AMF and IPA conducted a pediatric airway workshop just 2 weeks back. Today, I'll be talking about the common pediatric airway management problems and their solutions. Frequently, we use this term airway management. The purpose of the knowledge of airway management. Recently, the AMF way of airway assessment, that is the line of sight, was also published in RSACP journal.
There's no volume, Dr. Nishkarsh.
The management is very unique. It is usually easy and simple in most of the cases, but it can become a nightmare for the inexperienced. Reinforcing these concerns for airway management can never be overemphasized. In this endeavor, AMF and IPA conducted a pediatric airway workshop just 2 weeks back.
Nishkarsh, the volume is low.
Can you hear? Nishkarsh, are you sharing or am I sharing?
this term airway management.
There is we can't see the slides.
Yeah, you should
hear it.
Discuss what
Air or anesthetic gases from atmosphere or the breathing circuit of the lungs. And to maintain an airway patency so that this is possible. And most of the times for this, we need.
There is a confusion. I'll just do it.
Yes, we can't see anything.
Slides are not visible. Slides are not visible, and
The volume is also inadequate, Nishkarsh. We can't hear very well.
Manju ma'am, एक minute.
The device and the patients need to be created for managing the air.
Just stop sharing, then I'll share.
Mask over the face, or in the pharynx we have a supraglottic airway device sealing, or in the tracheal level we have the cuff of the endotracheal tube. This all is being done just to ensure adequate oxygenation and ventilation. Now, if this all has to be done by the airway management, there are certain rules which the airway manager gets. So let's see some of these rules. One is the airway assessment.
Can we start from the beginning?
Okay.
Yes, please. Just 2 minutes or so.
Okay.
That will be very nice. Thank you.
Dr. Kavita and RSACP for inviting me to this platform. RSACP and AMF have worked together on numerous occasions to spread the knowledge on airway management.
The volume, please.
Recently, the AMF way of airway assessment, that is the line of sight, was also published in RSACP journal. Pediatric airway management is very unique. It is usually easy and simple in most of the cases, but it can become a nightmare for the inexperienced. Reinforcing these concerns for airway management can never be overemphasized. In this endeavor, AMF and IPA conducted a pediatric airway workshop just 2 weeks back. Today, I'll be talking about the common pediatric airway management problems and their solutions. Frequently, we use this term airway management. The purpose of this airway management is to ensure an unobstructed movement of air or anesthetic gases from atmosphere or the breathing circuit to the lungs, and to maintain an airway patency so that this is possible. And most of the times for this, we need to allow placement of airway devices. Some of these devices also need a perfect alignment of certain structures or the airway passages, which needs to be done, and adequate seal between the airway device and the patients need to be created for managing the airway. This could be a simple face mask over the face, or in the pharynx we have a supraglottic airway device sealing, or in the tracheal level we have the cuff of the endotracheal tube. This all is being done just to ensure adequate oxygenation and ventilation. Now, if this all has to be done by the airway management, there are certain rules which the airway manager gets. Let's see some of these rules. One is the airway assessment. It has to be done by the airway manager. We have to optimize the airway whenever possible. Make a plan and a backup plan as needed. Choose and prepare the current the airway equipment and execute that plan. And this all is done while ensuring the safety, which most of the time just means oxygenation. But in case some complications occur, then to manage them effectively. So while we do all this, problems will come in some of the patients, but some of these problems are very specific for the pediatric airway. The problems are more so seen in neonates or infants or maybe toddlers, but more or less we can say that the airway of the children starts resembling that of an adult airway by the 7 years of age. So whenever we are talking about pediatric airway, we are usually referring to the airway in children usually up to 2 to 3 years of age. So let's see what problems do we commonly see. In airway assessment, the first thing what we need to do is take a focus history. So in history, the problem occurs many times. Who is the informant? The informant may not be knowing about the airway problems of the child, because the person who has got the patient to the hospital may not be living with that child or may not be knowing in details about the child. The availability of this history or the accuracy of this history may not be true. It may be considered irrelevant, like the parents or the relatives may not think that some problem which occurred at the time when the child was born has any reference or relevance now for this particular surgery. They might give some false information knowingly or unknowingly, because sometimes they don't wish to cut the sorry figure that they don't know about the details of the child, or they may not be knowing it. Sometimes they are under that impression that unnecessary giving these details regarding the airway will lead to a postponement of the surgery, just as because of ignorance, because they do not know that this has a relevance. So these problems very frequently occur in small children. So what we can actually do is just talk to the right informant, the person who lives with the child, maybe the mother, maybe the father, so that they can tell us that what is the right history. Does the child sleep with the mouth open? Does the child snore? Is there any drooling? So a rapport has to be made between the informant and the doctor who is dealing with that. Now the next problem is again the examination. Most of the time we find that the children are uncooperative. Well, that's what is written in most of the books. But somehow I have found them to be quite cooperative, as these children, this age group is the one where you can actually talk to them. Most of them, not all of them, but we can talk to them. They can be very easily distracted. Like you can talk to them about something which they like and you distract them. An adult patient can't be distracted on the table, or when he's coming in for a surgery, he's very concerned. The child is not concerned. We talk to them, play with them, they become friends, and we can actually get to do some examination. But there are limitations which are there. There are so many tests and indices which are there in adults. And these tests and indices may not be possible to be performed in children, or we do not have
radiological picturing done in many of the children. So
sorry for the inconvenience. So now is the voice clarity a little better?
Better.
मैं थोड़ा सा ना पीछे से चालू करता हूँ.
Yes, much better, Nishkarsh.
Okay, yeah, just started.
यहाँ से शुरू करते हैं सर. 2 मिनट.
Okay. Some of these problems are very specific for the pediatric airway. The problems are more so seen in neonates or infants or maybe toddlers, but more or less we can say that the airway of the children starts resembling that of an adult airway by the 7 years of age. So whenever we are talking about pediatric airway, we are usually referring to the airway in children usually up to 2 to 3 years of age. So let's see, what problems do we commonly see? In airway assessment, the first thing what we need to do is take a focus history. So in history, the problem occurs many times. Who is the informant? The informant may not be knowing about the airway problems of the child, because the person who has got the patient to the hospital may not be living with that child or may not be knowing in details about the child. The availability of this history or the accuracy of this history may not be true. It may be considered irrelevant, like the parents or the relatives may not think that some problem which occurred at the time when the child was born has any reference or relevance now for this particular surgery. They might give some false information knowingly or unknowingly, because sometimes they don't wish to cut a sorry figure that they don't know about the details of the child, or they may not be knowing it. Sometimes they are under that impression that unnecessary giving these details regarding the airway will lead to a postponement of the surgery, just as because of ignorance, because they do not know that this has a relevance. So these problems very frequently occur in small children. So how to deal with them? What we can actually do is just talk to the right informant, the person who lives with the child, maybe the mother, maybe the father, so that they can tell us that what is the right history. Does the child sleep with the mouth open? Does the child snore? Is there any drooling? So a rapport has to be made between the informant and the doctor who is dealing with that. Now, the next problem is again the examination. Most of the time, we find that the children are uncooperative. Well, that's what is written in most of the books. But somehow I found them to be quite cooperative, as these children, this age group is the one where you can actually talk to them. Most of them, not all of them, but we can talk to them. They can be very easily distracted. Like you can talk to them about something which they like and you distract them. An adult patient can't be distracted on the table, or when he's coming in for a surgery, he's very concerned. The child is not concerned. You talk to them, play with them, they become friends, and we can actually get to do some examination. But yes, there are limitations which are there. There are so many tests and indices which are there in adults, and these tests and indices may not be possible to be performed in children, or we do not have those numerical values. Sometimes those numerical values are there, like these distances, sternomental or something, in centimeters it is there. We do have normograms for children, and if needed, we can refer to them, but that becomes a bit more clumsy in children. So what should we do so that these problems are not there? A sharp eye, just have a look on the patient. What is happening? What is the status? What is the activity level of the child? Does he have any respiratory distress? What is the color of the baby? Is he producing any particular kind of sounds, like there could be some gurgling or snoring kind of a sound which is there? So this all we need to really keep a look. So look for retractions, look for congenital malformations. Most of the time the airway is easy in children, except in syndromic babies or some acute infective pathologies which are there, which lead to a rapid deterioration in the airway. So keep a lookout on these problems, like there is a preauricular tag or there's an extra digit. So these things we try and see, does this child belong to any particular syndrome? And we look for that. So the next thing what we have is investigations in airway assessment. Like in an adult, if there is a neck swelling, a big neck swelling, like a big thyroid or something, it's very easy. We just say like we need a CT scan or we need an MRI, and we see and look at the airway shadow and we try and assess. We can get scans done and all. But in children, to get a CT scan or get an MRI, we again need anesthesia. And for anesthesia, we need to do the airway assessment. So it becomes a vicious circle. So many times, many of these scans or invasive things or can't be done. We can't have radiological picturing done in many of the children. So look in what you have. Most of the times the surgeons have got some investigations, some scans done, so we can easily assess and see. A clinical assessment is always a better one in these patients. So the next step is optimizing the airway. There are many inflammatory causes which lead to a compromise of the airway. Like there could be nose blocks because of URI, some infections, reactive airway disease and all. Can we optimize them? More or less, yes. If there are increased secretions because of crying and you develop a rapport and the child, if you can probably make the child comfortable and less crying is there, then the secretions would be less and the airway would be probably more patent. Like this is one photo where there is an epiglottic swelling because of epiglottitis. So by giving certain drugs or medications or anti-inflammatory, we can actually decrease these swellings and make the airway in a better position. Any kind of a swelling, mucosal swelling in the small child's airway, because the thickness of the mucosa remains nearly the same. So if there is a swelling of maybe of 0.5 or 1 millimeter, that has a much greater relevance in children as compared to that in adults. A small increase in the mucosal swelling will lead to a rapid increase in the resistance to the air flow, and the obstruction can be caused. So if we use vasoconstrictors, a proper timing, like if there is a reactive airway, we defer it for some time if possible, use some anti-inflammatory agent, use nebulization. So then the swellings may become less and the airway can be improved. To decrease, we just keep aiming at decreasing the secretions. Once the swelling is less, the air passage is widened, and there's a decreased chance of airway trauma while we are doing some instrumentation. So the next step is the planning. We always have to plan our airway. So while we are planning, what do we do? Let's see and identify the available areas as well as the difficult areas. There are certain areas, when we have a difficult airway plan, we say like cooperation, face mask ventilation, supraglottic device placement. So these are the areas we look like what is possible and what is not possible, and what things are difficult but they can improve by using certain maneuvers. Like if the mask ventilation is difficult, can it be improved by putting in a by putting an oropharyngeal airway or something? So if we see what can be improved or what can't be improved, so available and difficult areas and improvable areas have to be classified, and we make a plan based on that. Along with that, we also see what is the surgical requirement. Like maybe a supraglottic device can be placed very easily, but the surgeons require an endotracheal tube in case they want to operate in the oral cavity. So then we have to consider that also. Look also for the resources available. I might be very good at video laryngoscopy, but if it is not present on that day, then I can't be choosing that as my plan. And also the manpower, the expertise, what is present that day at that time, we choose the best. So we make a plan based on that. Try and give some pre-medication or sedation. This is going to help in maybe reducing the secretions if we use an anti-salocog. If the child is crying less, then secretions are less. Some special equipment can be used in certain cases. Like if we are planning a fiber optic, in my plan, if I do a fiber optic and I also want to ventilate or oxygenate during that time, then I may use a simple thing like an endoscopy mask, and I can continue with both the things. So, and always remember, size matters. In children, it is not a uniform like an adult. Size matters. We do have children coming in from few hundred grams to nearly the size of an adult. So depending upon the size, our plan has to change. The equipment also has to change. What is available, we really have to check. What is there? Is it suitable for this particular size? So the physiological differences, many of them are there, which lead to, again, some challenges for airway management in children. There is an immature nervous system, and during respiration also there can be a problem. There can be an apnea of prematurity which can come and make our airway management difficult. Bradycardia keeps coming, but just remember, in neonates and infants, it is because of hypoxia until we have proven it otherwise. It is very frequently observed when we are manipulating the upper airway, especially if the laryngoscope tip goes and touches the epiglottis, then very frequently bradycardia is seen. So what we can do is limit the apneic time, keep oxygenating the patient, and handle the tissues with care. The amount of pressure what we are putting on these delicate tissues makes a lot of difference. Respiratory physiology also has a lot of bearing while we are managing the airway. The oxygen requirement in a neonate is as high as 7 ml per kg as compared to roughly 3.5 ml per kg in an adult. So this increased requirement is made up by mainly an increase in the respiratory rate. Also, there is a lower functional residual capacity in children, roughly 20 to 30 ml per kg, as compared to adult where it is 70 ml per kg. So this means there is a very low reserve in the child. The dead space ventilation as a proportion of the tidal volume is greater, and the horizontally placed ribs make the breathing more of abdominal kind. So, and the compliance of the chest wall is also high. So the chest wall would be sunken in case the airway is getting obstructed and the diaphragm is working against a obstructed upper airway. So you see retractions very frequently in children. So what we define is as a safe apnea time while we are securing the airway. So we see this is the time by which safely we can keep the child in apnea, and the saturation does not go less than 90%. So that is the safe apnea time. So this is the time where we can do our airway management safely. And it is dependent upon the oxygen reserves as well as the rate of usage of oxygen. It is till the time the saturation drops to 90%. And the good thing is it can be increased with oxygenation. And this increase is because that the dissolved oxygen in the blood has increased, and also the reserve in the functional residual capacity has increased. The main reserve adds up in the functional residual capacity. We must remember throughout that patient will never die because of failed intubation, but the patient can die because of failed oxygenation. So our goal should be always a good oxygenation. So how do we give it? Pre-oxygenation, that is giving oxygen before managing the airway. We can give it by a bag mask device or just high flow of oxygen over the patient's face. And sometimes the duration or the time needed to achieve this adequate pre-oxygenation is lesser in children because the FRC is lesser. Then the other concept is para-oxygenation, that is giving oxygen during managing the airway. It could be when the patient is in apnea or the patient is breathing spontaneously. And we have quite a few means of giving it. We have simple nasal cannula, so that can be used, and put it on the nose, and while we are doing the airway management, the oxygen is going. Nasopharyngeal airways with ports are there. We have oxyport, the straight Miller blade with oxyport is there, so oxygen can be given while we are doing the laryngoscopy. In case I am doing a FOB, guided fibroscopy, we can use an endoscopy mask, or we can also attach oxygen to the suction channel, and the patient keeps getting oxygen throughout. Apneic oxygenation along with apneic ventilation can also be done, because all the above methods, the previous methods of oxygenation, just increase the oxygen reserve, but the carbon dioxide level will continue to rise. Now, if we use an HFNC, high flow nasal cannula, or we use Thrive, that is the transnasal humidified rapid insufflation ventilatory exchange, it is such a high flow, it produces turbulence, and the CO2 levels also do not rise that high. Now, there are certain anatomical differences also between children and adults, which also cause some challenges for the anesthetist. So let us see, this is just a lateral view. If you see, this is like a 1.5-year-old child. What is very noticeable is that the head is big and the neck is small. This neck, which is small, will lead to a problem. The chin will frequently rest on the chest wall. So as we can see, the chin chest resting on the chest wall will lead to a pressure on the floor of the neck. So this floor of neck pressure can lead to an obstruction of the airway. The upper airway will get obstructed, the tongue is going to get pushed up, and airway obstruction can actually occur, and the patient may become hypoxic. To relieve that, what do? We just give a simple neck extension. We just extend the head here, the neck, it is extended and it opens. But we must take care that if we overextend the head, then also trachea can get kinked and there can be a further obstruction which is created. Now, if this is the normal situation, then how do we palpate the cricothyroid membrane? So the front of neck axis becomes very, very poor in these small children. So the landmarks are very difficult to identify. That is one problem. So now when we are holding a face mask, we make sure that the head is neither overextended nor it is flexed too much. And when we are holding the mask, the fingers do not push the floor of the mouth so that airway obstruction does not occur. Now, this big head also creates a problem in positioning. As we see in an adult patient, we use roughly 7 centimeter or 5 to 7 centimeter of a pillow or a head raise so that the external auditory meatus aligns with the sternal notch. So this produces an adequate alignment of the axis, that is the laryngeal axis and the oropharyngeal axis are aligned. So in a smaller child, we will use just a smaller size of pillow, maybe 3 to 5 centimeter. But in an infant, we may not require any pillow. And this alignment is achieved just like that because of the big head. While in a neonate, This big head is so big, that we need to use a shoulder rest and raise the shoulder so that this alignment is created. Now, the nasal cavity, if you look at that, this is one access to the airway, that is the nares. These small nares in the children, they limit the size of the endotracheal tube which can go through the nasal cavity. So this is the smallest area of the airway, that is the passaging in the nasal cavity. So we make sure when a tube is going in, there should be no blanching of the nostrils. So in case there is blanching, we go to a smaller size, and the direction goes along the floor of the nose. So, and if you look at, this is the medial wall, this is the floor of the nose, these are the turbinates. The mucosa is highly vascular and it's delicate. So any kind of instrumentation which is being done needs to be preceded by a vasoconstrictor and proper lubrication. In the oral cavity, the tongue is there. The tongue is relatively large. So it actually decreases the available oral and the pharyngeal space. So whenever we are doing laryngoscopy in a child, we must displace the tongue towards one side, and otherwise laryngoscopy becomes very difficult. If adenoid enlargement is there, that can lead to a problem in the nasopharynx. And if tonsillar enlargement is there, that can lead to sometimes obstruction and also difficulty in visualization. The larynx is higher placed, so that is another problem. It is lying somewhere just behind the tongue in a small child, C2, 3 versus C4, 5 in adults. The epiglottis lies very close to the palate. So if the epiglottis and the palate, soft palate, are nearly touching each other, the child keeps breathing from the nose. So if the child has to breathe through the oral cavity, the soft palate and the epiglottis are touching each other. So hardly any passage is there. So when the child cries, then a passage is created. So they become obligate nasal breathers because of higher placement of the epiglottis. The angle between the base of the tongue and the glottic opening also becomes acute. So the larynx seems very, very anterior. And so many times OELM is required. And this optimum external laryngeal manipulation is done with one finger of the anesthetist who is performing the laryngoscopy. This one finger we choose because single finger cannot compress very firm and cannot cause compression of the airway. So we use just one finger to give OELM and epiglottis is long, floppy, U-shaped, and many times lifting may be needed. So we see the first one like it's a neonate, the second one if it's an infant, and the adult one. So adult is an omega-shaped epiglottis, while in a small child, the epiglottis is U-shaped and is hardly getting lifted up easily. So if we have to lift it up, we can do it by our laryngoscope. The tip of the blade lies in the glossoepiglottic fold and lifts the epiglottis indirectly. But in case if it is too floppy and I cannot see the glottic opening, then I lift the epiglottis with the tip of my laryngoscope blade. So now in this laryngoscopy, we can't see the epiglottis because it has been lifted away directly by the tip of the laryngoscope blade. The vocal cords are also angulated. So anteriorly, they are lying more corded. So the tube, when we are trying to put in, usually gets stuck at the anterior commissure, and a simple rotation of the tube will lead to slipping of the tube in the trachea. And subglottic portion, that is the cricoid, is the narrowest. And previously we were using uncuffed tubes, thinking that they fit well into the cricoid, which is a full circle, but it's not a circle, it's more of an ellipse. So even when some leak is present, some walls, maybe the lateral walls, may still be having a greater than normal pressure on the walls. So it's, if possible, we may use cuffed tubes so that the pressure is more uniform in the tracheal level and not on the cricoid. The trachea is very soft and narrow and short, and cricoid pressure given if with greater pressure, it can lead to deformation of the trachea. Mucosal edema, if it is there, we have already talked about it, a higher increase in resistance is there. The depth of insertion, especially in the smaller children, roughly age upon 2 + 12 in children which are greater than 2 years of age. In lesser than that, an internal diameter of the endotracheal tube into 3, or the weight in kg +6, These formulae can be used in children which are less than 2 years of age. The correct size is very important, and the depth of insertion we've already said. So that is to be used. The length of the upper airway is dynamic, even in adults and even in children. So with flexion and extension, the upper airway length will change. So if endotracheal tube is fixed at one end, there would be a relative movement at the other end. So the tube tip may become endobronchial on flexion, or there can be an accidental extubation while we are extending the head. So most of the times, I used to think previously, many years back, that this extension or this increase in the length at extension is occurring in the upper airway, that is upper than the glottic opening. But many studies have been done, and they have found that this increase in length is mainly tracheal. The tracheal length will change with extension and flexion. When we are placing our supraglottic airway devices, then the sizes remain very important in these children. Like most of the times, the size is being chosen according to the weight of the baby. And if the baby is normal weighing, then the supraglottic device usually fits very well. But, when the children grow inappropriately, maybe they are malnourished, so they have grown, so the weight has not grown, but maybe the skeleton has grown more. So in an underweight child, it is preferable to use the supraglottic device according to the expected body weight, while in an overweight child, it is better to use the supraglottic according to the actual body weight. So we are trying to err on the bigger size, because when we use a bigger size, then we'll end up producing a good airtight seal at lesser airway pressure, lesser cuff pressures. So the cuff pressures must be monitored, and the fixing of the device should be done in such a way so that not much traction is there. And in case certain complications occur while during the airway management, we must identify them rapidly and manage them. As in pediatric airway, any secretions trickling down onto an irritable airway will lead to a laryngospasm. So it is seen very, very commonly in children. And in case it occurs, all of a sudden there is an airway obstruction, you are unable to ventilate, and the compliance decreases suddenly, and the child desaturates very fast. So try and give 100% oxygen, try and give a CPAP, give a Larson's maneuver, so you pressure, just pull up the jaw forward and behind the angle of mandible. If you push there, so the laryngospasm might break. And if it is not doing so, then we may need to give a small dose of succinylcholine and break the spasm and manage that airway. So to conclude, I have just very simple things which I have learned myself with this, that pediatric physiology usually predisposes to rapid desaturation in small children. And pediatric anatomy is such it predisposes to airway obstruction many times, whether it's the floor of the mouth or it is the big tongue. Short apneic times and oxygen supplements during airway management, they will always increase our margin of safety. Size matters. Whether it's the size of the child, it is the size of the equipment, it is the size of the drug what I'm giving to the patient, or it is the time, the duration, that size while I'm managing the airway. Each thing matters. We must plan. We make a plan for managing our airway. We plan which device are we using, and we also plan that who is going to be the operator, because children will require sometimes special operators, someone who is better experienced. And skills are perishable, as we have been taught by our mentors. Skills are perishable. If we do not practice, they go away. So we are supposed to practice them regularly. Thank you. Thank you so much.
Thank you, ma'am. Okay, so you can, any questions? So in the chat box, we don't have any. So
I'll pass it on to Dr. Anju to summarize the thing.
Thank you, Rakesh sir. An excellent talk by Dr. Kavita, very, very comprehensive, and she's really outlined all the anatomical and physiological concerns in a pediatric airway in a very organized and systematic manner. I would just like to add to this excellent talk and say that majority of the airways in children, for those of us who regularly do pediatric anesthesia, is seen only in syndromic children. You know, children who are generally syndromic, except for the small category of unanticipated difficult airway, is usually not difficult. And these syndromic children can be very well recognized by a detailed history, as she has said, and a simple examination will help us identify these children. In the examination, you must always remember that see the child from the side. As important as a front view, more important is a side view where you'd probably be able to see the shape of the chin and the size of the chin and the mandible, and any retrognathia or micrognathia is very, very visible from the side as compared to the front. A history from the parents or whoever stays with the child is very, very indicative of an airway problem. And the other thing to remember while dealing with a difficult airway is that not only should you have devices with you, but you should be well versed in use of these devices in terms of crisis. Crisis in a child, as Kavita has said, that inability to oxygenate is probably the greatest problem. And use of para-oxygenation, simply putting a nasal cannula while doing your procedure can take care of a very large number of problems. And then devices like use of a video laryngoscope and a supraglottic devices have taken care of a large majority of difficult problems. See, the problems in a child are probably more functional as than any other reason. So that every airway manager who's dealing with the pediatric airway should remember that simple things like holding the correct size mask, holding it properly, preventing any soft tissue bulge into the mouth. These are simple maneuvers which will take care of many airway problems which are related to bad use of devices or techniques in a child, because the obstruction is very, very many times functional. It's only in a small category that you actually have a difficult airway, and Kavita's outlined that very well. So that is my observation. Sir, you have to add that.
No, I'll request Dr. Maitri to come in, because at that point of time she could not chip in. So I'm sure that she'll have a lot to add to this, having worked all the time in the pediatric center like you. So over to Dr. Maitri.
Thank you, sir, and Dr. Kavita, very well presented. And you have covered most of the difficult aspects of a difficult airway. But I want to add few things. That sometimes a seemingly relatively simple airway or an easy airway turns to be difficult, especially when you are conducting a tonsillectomy. And somehow accidentally the tube comes out, and the mouth is full of blood. Then you should be you should have planned for those moments, that what you're going to do in such cases. And planning is very important. Even after securing an airway in a difficult airway cases, you must have plan B ready, because anytime the tube may come out, or even the surgeon may be so that they can pull out the tube. So what can you do in such cases? So a plan B should always be ready in such cases. And you must know your equipment well. It may be a simple thing like a laryngeal mask airway, or in which airways through which airways you can intubate these patients. So you must be aware of all these things, and they should be in your OT, and they should be present in each and every case. It should not be only that this is a difficult case, so I am keeping a difficult airway cart ready. So all these things should be ready in every case you are conducting, because deoxygenation can occur, or the patient may be in difficult times anytime. So you must be ready with that. And number two, that there are certain cases, though the front of neck access is very difficult in children, but certain cases like Ludwig's angina, which is a very difficult scenario. So in these cases, you don't have a front of neck access. So you have to be very careful while anesthetizing these cases, and you should never be afraid of asking for help. you should always call for no matter how senior you are. Another senior help is always better in such scenarios. Thank you.
Right. Thank you very much, Dr. Maitri, Dr. Anju, for those lovely words. And Kavita, great job done. And what I wanted to say was that you were to discuss the problems and their solutions. And it was very well presented that you kept on talking about the problems and giving us the solutions. And I also understood from your presentation that if we are smart enough, if we are vigilant enough, we can prevent those things from occurring. And also be ready, as Dr. Maitri and Dr. Anju have said, as and when the problem comes up. And I think another thing which you highlighted was that oxygenation is the key, and we can do it very easily by simple methods, which Ranju also highlighted, Dr. Maitri also highlighted. And ever since we have realized that even when we are not able to ventilate, we can still keep on oxygenating children or adults. And especially when you have talked about the reserves and the requirements, higher requirements, these become all the more important. And so all in all, a wonderful talk. Kavita, anything you would like to come in? Because when you put in a recorded chat, sometimes you want to add something. You can always do it now.
Okay, thank you, sir. Thank you so much. And I thought that maybe I might have issues with the internet, so I had recorded it. So that was the reason. And thank you, Dr. Maitri gave a very good suggestion that even once we think that we have managed the airway very well, we must be ready that in between an accidental something can happen and we will need to remanage it. And even when we are removing the airway device at the time of extubation, that is the time also we will again need to be very, very careful and manage the airway at that time also.
Oh, and of course, like children, the surgeons are also difficult to manage, you know. There are so many occasions, each one of us have found a tube being held, given to them and told in the middle of the surgery, कि ये जरा बाहर आ गई है, देखिए क्या करें इसका. So we all have gone through all that thing, and that has made our coronaries and the other arteries better. You know, we have become smarter and better because of all those small shocks which we keep on getting. But I can chip in one simple word about Dr. Maitri when she talked about, especially about tonsillectomy. I will tell some of the viewers, the younger people, that in the rose position, even if the tube comes out, that's fine. You know, the blood will come out through the nostril. Before it will go into the glottic opening. So don't change the position of the patient. Keep it in rose position unless you have managed till the time you have managed the blood. And once you have sucked out the blood, and don't forget the nasopharyngeal suctioning before you straighten the child for the intubation or re-intubation. And also you must understand that thousands of tonsillectomies are done with supraglottic airway device in place. So if you can place the supraglottic device before you straighten the patient, you will have a secure airway, you will be relaxed, your heart rate will be fine, and then you can re-intubate after sucking from the nostril and then taking out the supraglottic airway device only when you are ready with your plan B or C.
Yes, sir.
I'd like to add that when we are trying to assess what the difficulty of level in this child, any child would be, you know, trying to identify at which place the airway is going to be difficult is very important. Whether you have a difficult supraglottic device placement or a difficult laryngoscopy, or probably, you know, the mouth opening is limited, so you can't do any laryngoscopy. Identifying these prior to the procedure would really help you plan well. And getting it into your head that oxygenation is more important. You know, there are certain cases we've done where there was a large hemangioma on the lip and, you know, mask ventilation was impossible. So we never attempted that. We used a supraglottic device as a primary device for oxygenation. That means after induction of anesthesia, you directly put in a supraglottic device and use that to oxygenate a child. So trying to understand at what level the problem is going to occur will make our job much simpler.
It's very unfortunate, Dr. Anju, it's very unfortunate that you go out of Delhi, you go out of some big cities, and There are supraglottic devices which are lying. The people at the
Not
middle
being used.
and senior level are so scared to use them that
Yes.
they are not being passing down to the
Absolutely.
right people who are actually managing those cases. Dr. Navdeep also said that a senior person should be managing, but can't we be smarter that we make our juniors equal to us as early as possible, as Dr. Nishkarsh was saying, that I used to place the first year on the head end, and then he was the coordinator, and when he would be so foxed that at 6 months, but we all, Dr. Kaul is here, it's so nice to see his glowing face anytime, and I'm sure that when we all joined, we within a month or two we were sent for a cesarean, or but that was not the right method either, that we were thrown in the deep side of the pool without knowing how to swim properly. But that was another extreme. But I think a structured way of teaching in which the person within 3 months should know that all these things which Kavita said, which Dr. Navdeep has highlighted, which you have highlighted, Maitri has highlighted, that oxygenation is more important. You can give oxygenation without that. Supraglottic can be used much more often, at least if you are, even if you are an intubator in mind, heart and soul, I don't care. But at least buy your time, get your child under safe environment, and then reduce your own pulse, and then do the job at a leisurely pace. So I think all these things need to be, and I hope that all these seminars by RSACP and various institutions and various societies probably allow it to percolate down where we could not reach otherwise. And I hope
the skill-based workshops which we do are exactly for this purpose, disseminate this skill-based knowledge to the younger colleagues so that, they
No, not younger. No. That
not
is
younger.
where I differ. I want the middle level. They are the most important, most influential people, who actually run they are the backbone. So only juniors doesn't help. They go back and they are snubbed. So I want all the middle level people to understand, that they are in a golden period of airway management, golden period of pediatric airway management, and every management, in fact. So many things Dr. Navdeep said, Dr. Pradeep Bhatia chipped in with his lovely tube that he talked about. So I think we are all innovators at heart. We are, पहले हम उसको सरल हिंदी में जुगाड़ू कहते थे, अब उसी को innovation कहा जाता है. If you do it properly, and if we have the support, he said, he was talking about Ramson. None of our devices are actually supported by companies. Even with Modi Saab going all over the world, we have still not become smart enough to get the right funding and right people to support us. And I think it is for RSACP, for ISA, for all the things, and all of us, I am also equally responsible for that. So I have not been smart enough to infuse those things. So I think ज़्यादा जज्बाती हो रहा हूँ, तो यहीं छोड़ते हैं.
सर एक चीज और जो एम्फोसिस रह गया थोड़ा सा, वो एक कि पीडियाट्रिक एयरवे में इररिस्पेक्टिव ऑफ वो एंटिसिपेटेड है अनएंटिसिपेटेड है, हमें एनेस्थेटाइज तो करना ही है, so we have to give GA to these patients, majority of them, except for those who are slightly more cooperative, probably 5-6 year old, when they listen to you and you can do local. So आपको GA तो देना ही है. So you have to be well planned, well organized. And even if you give GA, as we've repeatedly said, if you can oxygenate during your fibroscopy or during your video laryngoscopy, GA becomes, is no longer dangerous. So, that fear of giving GA to a small child with a difficult airway will be done away with if you're well aware of your devices and you can oxygenate. So,
and Dr. Ranju, I want to add one thing.
Yes.
Am I audible?
Yes, please carry on.
Yes, sir. So as sir and at AMF, we say like we know our equipment and we know our procedure. In that series, I think we must know our surgeons. We are very, very comfortable if we have worked with those surgeons, because we know exactly which surgeon will leave a pack where, like cleft palate, they displace those flaps and they put 2 packs on the sides. Once I know that this surgeon leaves it, I am very careful. Which surgeon can leave a gauze piece? Which surgeon is more likely to, get your tube displaced? We are very comfortable once we know them. It's not like they might be operating thing and doing their procedure. But once we know, we are very careful and we can manage the airway in a better way.
Right. Well said. Well said. I think that's part of our, training, that
Yes.
the surgeons know their anesthetists and the anesthetists know their surgeon. And that is very much required, like in a very happy marriage or any happy relationship. Dr. Kaul, sir, आपसे आवाज नहीं सुनाई दे रही, क्या बात है? Sir, Dr. Kaul.
It is always good evening everybody.
Good evening, sir.
It is always, I have realized that the words spoken by Dr. Rakesh are always words which are weighed in gold.
क्या बात है, sir? क्या
They are
बात है?
not simple or ordinary words. The great learning for even me, and I am sure all the people who are listening, who are watching this.
सर आपने चाय नहीं पिलाई तो आप इससे बात बना के आप आगे नहीं कर सकते.
They are all you were taught. They are all there because of your training. And the best part today, what I like, is that the speaker said that it is not that a failed intubation will never kill a person.
Yes.
That was one of the golden words which must be percolated. That even if you have failed, ensure that the patient is managed the oxygenation so that the patient doesn't die. Failed intubation doesn't kill a person. That was really which was impressive. We have innumerable stories and anecdotes to speak about airway management. We have seen what Dr. Rakesh said, that the surgeon कहता है कि यार ये बाहर क्या निकला है, ये जरा ये देखो, and he sees the endotracheal tube. I used to work with those days, the patients for tonsillectomies, etc., would not be paralyzed. They would be kept spontaneously breathing, and that too on ether oxygen mixture. And then he would say कि यार इन्हों काट दे, a tube काट दे, मैंने जरा cautery चंगी तरह करना, I will just find the bleeders ligated. We have innumerable stories to talk and speak about it, and you learn a lot.
सर एक RSACP का सेमिनार सिर्फ इस पे होना चाहिए कि यादें जो याद रहें.
बिल्कुल सर.
Sure, sir.
Always.
Your views have given.
बहुत मजा आएगा उसमें.
I have learned a lot.
It will be impromptu, and I'm sure that हम सबको पहले ही बता देना 5 मिनट से ज्यादा खबरदार जो बोले. क्योंकि ये कहानियां endless हो जाएगी.
You are the king. Please go ahead. You can. It is already 8 now. I think yes, it is already past 8. Thank you. Both the speakers have been excellent.
Absolutely, sir.
Dr. doing an excellent job with Dr. Indrani, Dr. Vishal, Dr. Naveen. They are all doing an excellent job.
Dr. Navdeep का बहुत अच्छा टॉक था, दोनों का बिल्कुल.
And the daily branch of RSACP. Long live RSACP. Long live RSACP. Thank you.
Long live RSACP. Thank you very much, sir. Good night, sir. Good night, everyone.
Thank you very much.
Good night. Thank you so much.
Thank you. Good night.
Good night.
Thank you, everyone.
Dr. Navdeep. Thank you.
Thank you, sir.